Well, thanks for joining. Today we're going to be talking about technical rescue stuff, including confined space and crush injuries and things of that nature. Um, we're going to kind of go through the lecture portion, and then I'm going to pull up the protocols so that way we can take a look at what the protocols actually say. I did match the content, within the lecture, et cetera, to what the protocol says, but I still think it's a good idea to go over the protocol itself. Um, as is typical, I don't have any disclosures to report. So like I said, we'll go through, kind of crush injury syndrome, how we handle limb entrapments, confined spaces, and then some other specialized rescues such as suspension trauma and how we care for those patients, etc. So let's talk real quickly about crush injuries. The reason I'm starting with this is because we can see this in a bunch of the different types of technical rescues that we may encounter. With crush injury, it's typically a combination of both ischemia as well as the actual crush itself causing cellular death. Typically, when we see this occur is when the tissue has been compressed for more than 30 minutes. Um, 60 minutes, though, is one of the important time frames because that really tells us more about the risk of, somebody having significant, physical effects from crush injury syndrome. And so we'll touch on the treatment here in just a little bit. What occurs is not only are we getting the ischemia, but we're getting that compression and rupture of those cell membranes, et cetera. The ischemia as well is leading to lactic acid buildup, and so the tissue kind of distal to where the blood supply has been cut off, et cetera, is going to begin producing lactic acid since it's not getting oxygen. That lactic acid, causes pH changes, et cetera, which then change the metabolism of the tissue that has that pH. What occurs though is when we're now ready to extricate this person from whatever is causing their crush, and we suddenly release that pressure. That sudden release of pressure, can cause blood flow to be rapidly restored, which you would think is a very good thing. The problem is that that tissue that's distal to where the blood has been cut off is now full of toxins. It's full of potassium and myoglobin and lactic acid, et cetera, all of which are going to have, potentially pretty significant effects, and in some cases can lead to cardiac arrest. We know from study of a bunch of patients with this, that aggressive resuscitation while we're still in the act of extricating them can significantly improve their outcomes. Going through kind of the systemic effects, the hyperkalemia, we know that that can cause dysrhythmias, it can cause a widened QRS, peaked T waves, etc. Rhabdomyolysis is where, the muscle cells themselves have been, broken down, which then leads to leakage of the thing that gives red meat its red, which is myoglobin. Myoglobin is very similar to hemoglobin. It's a very, very big molecule, and unfortunately has the side effect of when it gets into your bloodstream directly, will begin to essentially clog your kidney. And so your kidneys will no longer be able to filter appropriately, and so you'll go into kidney failure. And unfortunately, that kidney failure can be permanent depending on the degree of rhabdo that you underwent. And then, of course, the lactic acidosis from the hypoxia is going to lower pH. It changes your other, metabolic functions because, again, the human body is, really supposed to be around 7.4. And so if we stray too acidotic or alkalotic, that can unfortunately really mess with our metabolism and our kind of cellular machinery. Um, the other thing that can occur with this is compartment syndrome. Unfortunately, sometimes this blood flow is compromised enough that once we release that pressure, et cetera, there's been enough damage that even though we've now restored blood flow to the area, there's been enough damage that that tissue now begins to swell, or we can begin to get leakage of the plasma, et cetera, out into the extracellular space. Um, and that is treated, unfortunately, typically with surgery. It requires potentially a fasciotomy, which is where we have to cut open essentially the fascia that's enveloping these muscles so that we can relieve the pressure, because otherwise that pressure just continues to build and will begin to compromise blood flow again, this time just from interior pressures. Luckily, it's something that I, knock on wood, have never had to do. We typically will try and get that person to the operating room with orthopedics to get it done. Trauma surgeons are also, trained in how to do these. So it's really critical that we recognize that crush injury syndrome is potentially in the differential whenever we've had somebody who is compressed for 30 minutes or more. And we need to, when we're able to, begin rapid, fluid resuscitation. That improves outcomes significantly. Now, completely understand the, environments that we're sometimes doing these in are not amenable to a ton of medicine. If we're doing something like an urban search and rescue where we've got somebody entrapped in a building, and we're actively trying to excavate them, from this, et cetera, that's a unique environment. And we're going to go over kind of the safety parameters on that here in a little bit. And so we need to do the best that we can. We may not be able to get a monitor next to them. We may not be able to, get in there with the ability to give them a ton of pain meds and things like that. We should, in situations like this, try and get IV fluid, because IV fluid in and of itself is going to help significantly with, hopefully preventing this syndrome from occurring afterwards. So try and at the very least work with the rescue team who's going to be, potentially extricating this person, to see if you can get it accomplished. Hopefully, this is someplace where we can get to them, where, this is industrial machinery, et cetera. There's plenty of room around, and we just need to work a little bit to get them out. Then maybe we are able to accomplish, more stabilization and resuscitation than we'd otherwise be able to if we're down in a hole, for example. We also need to make sure that, especially when we're dealing with building collapses and things like that, that we're not, kind of missing the other potential injuries that may have occurred with this. So make sure that you're going still through and doing your rapid trauma assessment, and really try and pin down as much as you can how long that person may have been entrapped. Our protocol says that if they've been entrapped for less than 60 minutes, we want to give them a 1 to 2 liter normal saline bolus. If they've been entrapped for 60 minutes or more, we need to alkalinize that. So we're going to add sodium bicarb to this IV fluid. So typically we'll do 1 amp in a 1 liter normal saline bag, and then you administer that at 1 to 2 liters per hour, and that is throughout. Okay, so if we're going to be extricating this person over a 3 hour time frame, they're going to get between 3 and 6 liters of this sodium bicarb normal saline. And the reason for that is, especially when we have these prolonged extrications, not only is the fluid resuscitation, a good thing for hemodynamics, but it also begins to alkalinize their urine. Myoglobin, when we begin to alkalinize the urine, has less of a profound effect on the kidneys. There still is going to be a degree of kidney damage, but we kind of want to dilute things down a whole lot. So as long as this person is not bleeding, we can give them this fluid, and you know what? They're going to start peeing. And if you're down in a hole, they just pee. If you're in an industrial setting and you can get, one of
Donation.
those urine jugs, et cetera, over to them to pee in, great. But, we want to try and get them peeing, pretty rapidly, because that again is going to hopefully lessen the effects of that myoglobin. Especially as we get close to the point where we're getting ready to remove the pressure and extricate this person. When we're able, we need to try and get them on cardiac monitoring. And the reason for that is because as we begin to release that pressure, that's when the potential for the lactic acid and potassium and myoglobin have their opportunity to kind of, get out and can cause the dysrhythmias, et cetera. A sudden influx of potassium in and of itself may be enough, if it's significant, may be enough to put this person into VFib. So we need to make sure that we're, very cautiously, doing this. And when we are able to, we get them on cardiac monitoring, plus or minus, pads. So this is a graph that shows kind of the survival rate. And, as you see, the earlier we get to the person, the better off they're going to do. The longer somebody's been entrapped, the lower their survival rate. So when we get out to that 360 to 480 minutes, we're down to potentially a 50% survival rate for folks. But then as we get further away from their extrication and we get them to the emergency department, and to the intensive care unit, they do better. Now they're getting their treatment, et cetera, but they're doing better. So again, it's really, really important that we, obviously scene safety is the most important, but we really need to work with kind of incident command on trying to figure out, what we can safely accomplish as far as medical resuscitation, goes. Um, After we've gotten this person potentially extricated, we again need to get them, assessed as if they're trauma. So start all over again, with your rapid trauma assessment. Go through, make sure you're not missing other injuries, et cetera. So when we get hyperkalemic, again, we're going to have peaked T waves. That's the earliest sign of hyperkalemia. And then we're going to begin to get QRS widening. That's typically greater than 0.12 seconds or 120 milliseconds. Once we're to that point, it's pretty significant hyperkalemia and can rapidly begin to worsen. The next step is typically we begin to lose kind of what the P waves look like because the P waves have also become somewhat slurred. And eventually we get to that sine wave pattern of that undulating wave, going back and forth, where it kind of is hard to determine whether or not, something is a QRS or a P wave or a T wave, et cetera. It'll begin to kind of slur everything together. And that's when this person is critical and, is getting ready to go into cardiac arrest. So once we begin to see signs of this, which again, we hopefully have, lessen the chances of because of the fluid resuscitation we've been doing. Once we recognize this, we need to begin giving calcium per our calcium administration protocol, which we're going to go over again here in a little bit. You can also give sodium bicarb, albeit it has to be in a separate line from everything else. If you remember, sodium bicarb is basically not compatible with anything. And so make sure that you're being careful with that. And then we can also give albuterol nebulizer. Albuterol does help drive potassium intracellularly, and so it can buy you a little bit of time while the calcium is getting around, while you're getting the IV fluids, circulating. So that initial fluid bolus is going to be, again, 1 to 2 liters normal saline. And whether that is, alkalinized or not depends on how long this person has been potentially entrapped. But it's, again, really, really, really important that we get this person that IV fluid. So let's go through the timeline really quickly for how we're going to handle one of these crush injuries. So we're initially going to go down and, whoever is qualified to be in that environment is going to need to do some sort of rapid assessment and figure out kind of the environment that we're working in, the safety parameters, et cetera, and begin to formulate, a plan, not only for the medical treatment for this person, but also for the scene safety and for the eventual extrication and what kinds of equipment you're going to need. So again, initial priority really does need to be ABCs, but also then initial IV fluid resuscitation with or without sodium bicarb. Again, if it's an environment where we can get a cardiac monitor in there, great. Let's get cardiac monitoring in there. Potentially talk about pain meds, and that may mean that we're going to do intramuscular meds, because we can't get great access to them. So kind of help develop a plan with incident command. Then, incident command needs to coordinate this extrication process because we need to make sure that as we're beginning to extricate this person, that we're doing it in conjunction with the medical team. Before, relieving pressure off of this, we need to consider potentially placing a tourniquet. And the reason for that is because with the tourniquet, we can, in a more controlled environment where we can have them on all kinds of extra monitoring equipment, et cetera, begin to relieve that pressure ourselves, as opposed to relying on, the building or the machinery, et cetera, slowly releasing this. So generally, if somebody has been entrapped for, more than 60 minutes or so, we're probably going to recommend that a tourniquet be placed. And we get that tourniquet in place, and begin to relieve, the pressure off of that injured body part until we can get them, hopefully, completely extricated. Once we've gotten them extricated, we need to, of course, get out, reassess them, ensure that there's no other injuries that need immediate treatment, such as has the tourniquet been effective, or are we now beginning to see arterial bleeding, distal to where the area was entrapped? Are we beginning to see EKG changes consistent with hyperkalemia? Are we seeing signs of compartment syndrome? So that way we can begin aggressively treating those and recognizing those and giving a heads up to, the trauma center. One thing that is becoming more and more and more accepted is active involvement of medical direction in this whole process. There are numerous medical directors around the country who are qualified to go down into urban search and rescue environments, or have had enough training to understand kind of these special circumstances, et cetera. And actively involving them, even if it's just via telephone, really can improve outcomes because the medical director can help guide kind of what the priorities are, can kind of help direct, where we should be placing the tourniquet, things like that. And also, let's face it, sometimes we need to do, field amputations, which we will talk about here shortly. In which case they can help guide the decision making on that and show up to hopefully be able to perform this procedure when it really unfortunately gets to that point. So actively get medical direction involved early. UC Air Care has, a physician that can come out most times. They can also, if they're not at main hospital, they can also stop, pick up a trauma surgeon, pick up, the necessary equipment, and fly out to that scene with somebody who's capable of doing amputations if it's needed. Um, I'm available. I'm not urban search and rescue. I'm not going to go down in some concrete hole, etc. But I know enough to, help guide the resuscitation. So feel free to give me a call as well. But we do have multiple docs in the area that are on the urban search and rescue team, and are more than capable of helping direct, these kinds of resuscitations. So let's talk real quickly about compartment syndrome. I know we've talked about it a few times already, but I think it's important to remember it. So the prototypical area that we think of as developing compartment syndrome is the lower leg. There are a ton of muscles, a ton of different fascia compartments in there, and not a whole lot of space. So any kind of injury to this area is potentially going to, cause swelling of this tissue. And because of the amount of fascial planes that are within the lower extremity, that means that there's not a whole lot of room for things to swell and expand. Unfortunately, what that means is that sometimes compartment syndrome is going to develop. We need to make sure that we recognize it early because, similar to crush injuries, the longer compartment syndrome goes on, the more profound the effects are going to be, including, ischemia, limb loss, nerve damage, etc. So the earliest warning sign that somebody is beginning to develop compartment syndrome is pain that's way out of proportion to exam findings. So this is that person who, has sustained an injury, etc. And, you go to move them even just the slightest little bit, and, they're hanging off of the rafters of the building. That unfortunately, represents, potential early sign of compartment syndrome. There are the classic five P's that we talk about with compartment syndrome, which is pain, typically out of proportion, all right, pallor or paleness, pulselessness, meaning we can't feel a pulse, paresthesias, numbness, tingling, etc., and then paralysis. Paralysis is now to the point where we're not even able to move because of either the muscle itself being damaged enough, or the nerve itself has been compressed and damaged enough that it's not able to pass along the signals. We need to make sure that we recognize this. There's not a whole lot that we're going to do for this in the field other than recognition and pain management. But alerting the hospital ahead of time that, hey, I think I've got somebody whose pain is way out of proportion. I'm concerned, given their mechanism, that they maybe have developed compartment syndrome. Um, you know, please be prepared for that. A good assessment that you can do in the field, for this, again, it's not super specific, um, is the passive stretch. So if you take somebody's lower extremity and you point their toes down towards the ground, or point their toes up towards their nose, and that passively, and that causes really significant pain out of proportion, that may be an indication that this person is beginning to develop compartment syndrome. Again, most commonly seen in the lower extremity, but you can see it anywhere. I personally have seen it develop even in the deltoids, which at the time I didn't even think was possible. But you can develop it in any part of your body, where you get this significant swelling and you've got tight fascial compartments. All right, let's talk quickly about, limb entrapment. So with limb entrapment, we are going to have limited access potentially, to be able to assess the limb in its whole. Try and do whatever kind of neurologic assessment you can. Again, try and do whatever kind of circulation assessment you can, while of course, maintaining priority over, potentially IV fluids. So if we've got somebody that's in there with, significant pain, et cetera, it may be that, we need to do pain management. Again, tourniquet timing, is important, fluid resuscitation, and then, early consultation with medical control. Get somebody involved early on, who can help guide you throughout the entire thing, and can help make the decisions on, kind of medically what are our next, priorities. So when we're, dealing with this, we want to make sure that we're assessing either the distal pulse or, cap refill every 15 minutes or so. And we also want to try and document their neurologic function. Are they able to move things? What's their sensation like, et cetera. That's going to tell us a lot about the salvageability of that, distal extremity, pretty early on. Um, Whenever we've got somebody who's got an entrapped limb, not only do we have to worry again about that crush syndrome that can occur, but we also need to worry about, bleeding. Has this crush injury, ruptured the vasculature down there, and are we going to get, considerable, blood loss if we remove this? So the tourniquet kind of has in those situations a twofold purpose, which is, preventing this crush syndrome, sequelae from occurring, and also preventing any bleeding if there is arterial compromise, distal to this. We definitely need to have it in place for anything over 2 hours duration, but really most people are now beginning to recommend, given the safety profile of tourniquets, that anything over 60 minutes, we probably ought to be putting a tourniquet on this person so that we can, in a more controlled environment, begin to release that blood flow, and instead of allowing a massive influx of potassium all at once. Instead, we allow, a small amount over a prolonged period of time. It's important that we roughly document the application time and continue to reassess that circulation status if we're able to distal to that extremity. All right, field amputation. This is something that, frequently gets talked about, but is not something that gets performed all that often. It's funny, when I was looking for images of, trainings associated with field amputation, I found this Gentleman's Guide to Amputation, themed after the 1800s, etc. So if you need to, I suppose you can print that out for the time when nuclear warfare has occurred and you're now kind of on your own in the wilderness. Um, the equipment that you're going to need, to have for this are tourniquets, obviously pain medications and sedation, ideally resuscitation equipment, and the surgical equipment to perform amputation. It's very, very, very important to recognize that this is not in the scope of practice for anyone in EMS. This is a physician only, kind of procedure. All of us who have done EMS fellowships are trained in how to do these. Again, the trauma surgeons at University and at Bethesda North and at Westchester are all going to be capable of doing this as well. In an ideal situation, we are going to use surgical equipment to do this. And so I know that UC has kind of a kit already put together that they can grab and bring to a scene. I trained in an area where, basically it was the EMS physicians who were going to have to be the ones to perform these. Um, in training, you can, use stuff as simple as a Sawzall. We did a training scenario when I was still teaching in the EMS fellowship, various ways of cutting through, for example, femurs, tib fibs, etc. A lot of people will talk about using one of those Geely saws, which is one of those kind of rope saws that has the two rings on the end, and you kind of pull it back and forth, very slowly. That takes a lot of time. And in doing so, you're now exposing this person to more pain, more of the hazardous environment, etc. What we found in training was that the use of either a proper surgical saw, or in the absence of that, where we really need to get this person out and we can't wait for the proper surgical stuff to arrive on scene, is to use a scalpel to get down basically to bone, and then use a Sawzall, and very quickly get through that bone. And then, it's on us and the hospital to then, take this person back to the operating room once they get there, so that we can refine this, because obviously using a Sawzall, not the best. It's not going to be sterile. The equipment is not designed to do this. But this is something that if you're in an absolute pinch, the doc may say, "Look, I just need a Sawzall. Just give me the Sawzall. We'll deal with infection. We'll deal with bleeding and stuff after the fact." But that was what we found. If you're not able to get a surgical saw, a proper surgical saw, that was what we found worked the fastest, and was most reliable. Obviously, that Sawzall is written off. You're never gonna get it clean. And so that's the understanding when you do something like this, is that that piece of equipment is now no longer usable. It's biohazard. So Again, hopefully this is something that none of us ever have to experience or have to do. But I, a couple times a year, will kind of think my way through how I would do one of these if I were to ever, hopefully not, get called, to have to do one of these types of procedures because it's brutal on everybody. All right, we're going to talk real quickly, or we're going to show a video real quickly of kind of the background on one of these that got performed. Hopefully, I think I've got sound sharing, so hopefully you guys are able to hear this okay.
I've been a trauma surgeon for 20 years. It's the first time I've had to go out in the field.
We knew at some point this type of thing was going to come up.
In response to the requests from the community via the first responders, Dr. Gamber came to us, and over the course of a month or so, we kind of put this plan in place.
Some of our community fire departments in the area, it was in discussions with them where they said, there's so much construction up here. We see a lot of construction injuries. We deal with some very difficult extrications from heavy machinery, from ditches and other areas.
In this case, there wasn't much doubt from the beginning as to what needed to be done.
I got a call from the Frisco Fire Department. They were en route to a scene in which there was a patient who was trapped in a piece of heavy machinery. At this point, we activated a field surgical team.
Scalpels over here.
This was the first time we've activated that process.
And there was a brief discussion on what the quickest way and the best way to get me out there was. The helicopter was going to be transporting the patient from the scene to here, and it was kind of on their way basically to stop here, pick me up, and take me to the scene. 5-10 minutes after I spoke with Dr. Gamber on the telephone, the helicopters landed. Next thing I know, they're shoving a helmet on my head.
We were sure that he was trapped in such a manner that it was going to be very difficult to remove him from the machine.
And it seems sort of counterintuitive, but the first thing you do is ignore the obvious. You ignore that main stuff, and you're worried about this patient breathing. Once you kind of get that under control and you have a plan in court, and there was a lot of coordination between me and the firefighters. Okay, when this happens, this is going to happen. You need to be ready to do this and this.
We were able to keep the patient comfortable throughout the entire process. We really kind of took an operating room environment, granted windy outside on a construction site, but when you think about what was given and how the patient was cared for and the teamwork, it was a very similar process, and I think that's why we're going to have a good outcome here.
So, pretty powerful. Luckily, that person ended up doing okay. More and more though, especially if you've got an EMS physician who's helping make these decisions, etc. The rush to do a field amputation, I think has been mitigated somewhat with involvement of EMS physicians and folks who are comfortable doing field resuscitations. Because, unless this person is in imminent danger, maybe we just need to slow the pace of things down and do a more methodical and slow extrication of this person. Taking our time to potentially salvage that limb, and avoid doing, a field amputation if we take an extra 45 minutes. And we've got a patient who's, we're able to get easy access to, we're able to get on monitoring, we're able to get their pain adequately controlled, we're getting fluids into them, etc. Taking a more methodical approach is going to benefit that patient. We're going to potentially salvage that limb, and also hopefully lessen their chances of infection or surgical complications. There was a lecture a couple of years ago done by an EMS physician in Florida, Dr. Ben Abo, ABO. If you ever are interested in learning more about this, I believe he's got some YouTube videos that are up there, but he did an excellent presentation on his experience throughout Florida of helping do these kind of slowed down, special rescues where, because he's there on scene, he's able to, direct the resuscitation in such a manner that they're able to salvage people's limbs, able to keep them from, having a more dangerous extrication, etc. for the sake of time. And instead, he in a couple of the cases he illustrated was really able to, salvage people's extremities and keep them from needing field amputations because he was there and able to, help guide that resuscitation and had a little bit more comfort level with kind of the long-term resuscitation that frankly happens in the emergency department and the ICU, but doesn't happen in the field all that often.
I've been a trauma surgeon.
All right, pivoting a little bit. So confined space rescue. This is again something that we also may encounter as part of any of the crush injury syndromes or limb amputations that may need to occur. Some of these areas are down in confined space. A big concern is that this environment may not be safe. There are numerous cases of patients being stuck down in petroleum tanks or other kind of tanks, sewers, that kind of thing, where it's oxygen deficient or there is a gas that's present that overcomes them. Unfortunately, very common in sewer and manure pits because the hydrogen sulfide gas that can be present there is a direct asphyxiant. It interrupts your body's ability to use oxygen or to carry oxygen. And so, one or two breaths of that, and that may be enough to kill you. So there is a lot of training that goes into confined space rescue because of all the dangers associated with not only the atmosphere, but also the hazards present just simply being in a confined space. It's important that these teams are doing lots of atmospheric assessment, that they have adequate airflow. They will spend a lot of time making sure that the atmosphere is safe to operate in, making sure that they've got adequate inflow and outflow of the environment to keep things, hopefully safe. It's also important that they're monitoring temperature extremes because, again, if you're in a tank that's above ground in the hot summer sun, that can get pretty hot in there, and so it's important to be monitoring the temperatures as well. Also, because of the type of things that they're doing, there is this potential for, explosive fire. Unfortunately, dusty environments, et cetera, are explosive environments a lot of times. And so, even though we may be in a grain bin or something like that, if we stir up a lot of dust, et cetera, that poses a fire risk. And we need to be cognizant of that and hopefully mitigate that as much as we can. Again, similar to when we're dealing with crush injuries, we need to be kind of prioritizing our medical care, according to what we're able to accomplish. It may be, especially if we're in an atmosphere that may be potentially explosive or may have the potential for significant fire, that we're not able to bring a cardiac monitor down there. It may be that the atmosphere we're not able to get changed over fast enough, and so there's real concern about us introducing supplemental oxygen to the patient because that supplemental oxygen is going to spill over into into the rest of the environment. And so if we're not able to get that environment changed over quickly enough, that ups the fire risk, that ups the explosion risk. So we need to be careful with that. So keep these things in mind when you're beginning to formulate some sort of a plan with incident command, who is, hopefully trained in these confined space rescues. If you're not trained in this or urban search and rescue, you absolutely should not be going into these environments. We've got resources, locally that we can call on where we do have these folks available very, very, very quickly. Again, with these confined space, issues, it's important to have medical direction involved. That way you can have some physician involvement in, just ensuring that we're doing things. There's a very unfortunate but famous case that we talk about in confined space rescue out in Texas from, I think it was the late 80s. where petroleum workers were hired to refurbish one of the above ground storage tanks. And so the first worker, tests the environment, the environment at the top is testing safe, that they've adequately aired the place out over the subsequent, couple of days or whatnot. So lowers himself down into the, tank and gets down to the bottom and very quickly collapses. So, unfortunately, his coworker decides to go after him and very quickly becomes overcome. And when rescue arrives there, they very quickly are trying to, work on getting these people out of the base of this. It takes them about 45 minutes or so before they're able to get the necessary equipment out to this place. A couple of firefighters ended up being overcome themselves, but were able to be rescued. And the long and short of it is, by the time that equipment arrived there, those guys were dead. There was no rescuing the two men that were at the bottom of this petroleum tank because they'd been asphyxiated for so long that there's no chance of salvage. And so having medical directors involved in kind of helping plan kind of the rescue or recovery can be very helpful, because we can help guide, is this a recovery or is this still a rescue? Are these folks still alive, or are they more likely dead? And if they're more likely dead, we can slow the pace down, not take unnecessary risks, et cetera, and be a lot more methodical than a rescue sometimes can be. It's also important that depending on what kind of a confined space that you're in, you may need decontamination, because it may be that you're in an environment where you're exposed to a bunch of really nasty stuff and it needs to get cleaned off. There are a bunch of OSHA guidelines and regulations around confined space because of the significant danger associated with them. Typically as a 4-person entry team that has atmospheric monitoring, they've got adequate communications, they have emergency retrieval capabilities, et cetera. And again, we've got to be very, very careful about the types of equipment that we're bringing down into these confined spaces, because of the potential explosive hazards and atmospheric hazards that are there. So very, very, very important that we're using intrinsically safe equipment, which at the very least all of our radios are supposed to be intrinsically safe. So very important that we understand kind of the danger that we're bringing when we bring equipment in. So when we decon, of course, it's, we want to decontaminate with typically just water, if somebody's been exposed to something. So, obviously get the patient deconned if they have, any of the material still on them. If this is a gaseous tank, et cetera, it may be as simple as us removing them from the tank was enough to decon them. There's no gas now trapped against them, et cetera. But if it's a solid or a liquid, it may be that we need to get that off. So make sure and try and get that off before you put them in a different confined space, i.e. the back of an ambulance. All right, so we're gonna watch another video, again, kind of going over the risks of sewers.
Big story at 6 o'clock. 2 workers killed on the job yesterday, now identified.
Police say 31-year-old Garrett Robertson and 51-year-old Heber Rivas are the men who passed out and died while working on a sewer line in Mobile. WKRG News 5's Christina J. Harris joins us. And Christina, investigators are still looking into exactly what happened.
Yeah, Mobile police say the men appear to have been overcome by some sort of gas, but the exact cause of death is still under investigation. 2 miles down this service road in the Princeton Woods subdivision in Mobile is a sewer line that's now become the focus of a work-related death investigation.
We discovered 3 people down in a manhole there.
2 of those workers died, and a third is now hospitalized. Stephen Millhouse with the Mobile Fire Rescue says a few things stuck out to the firefighters who responded on Monday.
In a confined space environment, one of the first things that you think about in confined space is oxygen deprivation. And then the site itself, where we were, was a sewage bypass. So you consider all sorts of, okay, there could be oxygen deprived environment, or there could be other gases in that environment.
Before firefighters began recovery efforts, they used this, an air monitor, which determines the safety of the air quality. When the air is safe, the reading will be in the green. But if you put it in unsafe conditions, the monitor goes into the red and sounds an alarm. Millhouse says the firefighters used the monitor. The test indicated the air quality was safe.
We want to be able to test the air quality there, make sure, again, it's safe for our crews to go in and access these patients. So we can't help you if we're victims ourselves in any situation.
So what remains unclear is exactly what conditions those workers found themselves in before firefighters arrived. Firefighters train regularly throughout the year for rescue operations like this, but the interim fire chief says this is the first time in 10 years they had to put that training into action. In Mobile, Christina J. Harris, WKRG News 5. You heard it there, folks. Live in Mobile, I'm Christina J. Harris, WKRG.
Big story.
So, very quickly, something that, is a routine thing for sewer workers can become deadly. I'm not clear on what they ended up, finding as contributing factors to that. My guess is that they didn't have one of their gas monitors with them when they went into this originally. And as a result, the most likely cause is either oxygen deprivation or hydrogen sulfide gas. Their monitors are supposed to be monitoring for that and alarm. My guess is that by the time fire and EMS arrived with the appropriate monitor themselves, the manhole cover had probably been, open for long enough, et cetera, that there may have been some just passive ventilation enough that the initial environment was significantly different from the environment that fire and EMS arrived to. I'm not clear on what the coroner ended up finding, but there's blood testing that we can do to determine if it was hydrogen sulfide or not. But very important that, something that these guys are encountering every single day. One slip up of forgetting to turn your monitor on or bringing your monitor with you, can cost you your life. Tank rescue protocols are very, very similar, if not exactly the same as, confined space. They are considered a confined space because of their nature of, storing things. Again, there's a little bit more of a risk of contamination. And so it's important that, what was stored in this and what kind of medical effects you may need to mitigate from exposure to those chemicals, and or how you're going to, decontaminate yourself and the patient following a rescue out of a tank. Pivoting a little bit, let's talk quickly about suspension trauma. So suspension trauma is when we have someone who is in a harness, and that can be an industrial worker who's in a full body harness, or a climber who is in just a climbing harness, etc. What happens is these folks will lose their footing and, essentially be suspended from their harness itself. The act of being suspended by these harnesses, yes, does save them, but if there is no way to quickly lower them to the ground or to get them back on their feet, unfortunately, those harnesses, by their nature, are going to begin to cut off, especially femoral blood flow. And so what can happen is this suspension injury syndrome will begin to occur. So we'll compromise both venous return from the legs, but we'll also compromise arterial supply to them. As this occurs, blood begins to pool down in the lower extremities. The lower extremities also begin to signal, hey, we're not getting enough oxygen flow, so we need to dilate to get more blood flow coming into this area. So we get this pretty significant dilation of the arteries down there, trying to improve this blood flow. And it becomes this cycle of, we've now dilated the blood
My meeting will be done in
vessels.
like 10 minutes.
Oop, sorry, if you guys can mute your background, please. We'll get this dilation of the arteries, coupled with this venous pooling, because we're not using our legs, we're not pumping our calves, we're not moving our knees, etc. And so this will begin to become, pretty significant problem. In these prolonged suspension cases, there can be as much as an 85% reduction in their cardiac output. So that is profound, and means that they're going to get tired very, very quickly, and they're not going to be able to exert themselves the longer this goes on. This really is critical in about 20 minutes. There's not a lot of time before this becomes a real problem. So something that is really bad. As the suspension, continues to prolong, as more blood begins to pool in the lower extremities, it begins to deprive, the heart as well as the brain of blood flow, and this can add to confusion and, again, worsening cardiac output and things like that. If you arrive on one of these scenes before, urban search and rescue has potentially arrived, you want to try and get this patient horizontal. So if they are in a position where they can kind of maneuver themselves to get where they're level, their legs are level with the rest of their body, that's something that they can do. More and more places are providing, these industrial workers with suspension straps. We're going to watch a quick 2-minute video on what a suspension strap is. But it's basically a strap that you can attach to the harness itself, that now gives you kind of this web that you can stand up on to get pressure off of those femoral supply. When we have somebody that has this ongoing, if we're able to get access to them, we need to try and do medical monitoring. We need to try and do IV fluids, again, because of the essentially, it's almost like blood loss, because the blood is now stuck in the lower extremities. So trying to give them some IV fluids, can be beneficial. But the main priority is getting the weight put back on the feet or on the knees and off of that groin area. All right, here's that video kind of showing you what these suspension straps look like.
My name's Tucker Burquest. I'm the 3M Fall Protection Specialist for Western Pennsylvania and Northeast Ohio here. Let's all pretend for a moment that I'm a coworker of yours, all right? So we're in the mill together, we're working on the same shift, and now you hear me yelling, you hear me, you look over and you see I've taken a fall here, right? How are you gonna get me down? A lot of times when I ask that question, a very common response I get is, Tucker, well, we'll just call 911, right? Well, 911 should be a part of your rescue plan, shouldn't be it in its entirety. The reasoning for that is I'm starting to get what's called suspension trauma in my legs right here. So this is cutting off the circulation of my femoral arteries. They say this takes about 15 minutes to become life-threatening. Could be a little bit longer, could be a little bit shorter. There's a lot of factors that go into it, right? So if I do take a fall, I want to make sure I keep my legs moving, I keep that blood flow pumping. Now, luckily for me, here's a little 3M plug for you. I'm in a 3M harness. And most of our harnesses now come outfitted with what we call suspension trauma straps. So I have a hook on one side, I have a loop on the other. I'm gonna find the loop that's closest to my knee. I'm gonna put the hook through that loop. And now I've created myself a sling that I can step into. And now I can step up and relieve that pressure off my legs, right? So now I've bought myself a lot more time in order to get that rescue plan enacted.
So, I mean, it's a really simple, piece of equipment, but, can really drastically change, kind of the urgency with which we're trying to get these suspended patients, down. even if somebody does not have proper suspension straps outfitted as part of their harness, this is something that it's simple enough that you could probably rig something up to attach to the harness so that you can begin to get that pressure off of that patient while you're trying to figure out how to get them down and extricated from things. But these are kind of nightmare scenarios where you've got equipment failure, and you've got other hazards that are present, also potentially hanging with the patient, such as electrical equipment, industrial equipment, things of that nature that compromise your ability to get safe access to them. So being able to rig something up like these suspension straps can buy you a lot more time and allow you to be, again, a lot more methodical with figuring out how you're going to safely, get this person out of the danger zone. The guy is not exaggerating. This is a 15 to 20 minute time frame before this begins to really profoundly take effect. And the longer somebody is up there, the more concerned you should be because of the venous flow. It also is important that if somebody has been hanging for a prolonged period of time, very similar to crush injury, we don't want to rapidly lay them horizontal because again, that blood flow is going to potentially have some toxins, and so we're going to want to do it in a little more controlled environment. So taking a couple of minutes to do it. As opposed to rapidly laying them down on a stretcher, et cetera, and potentially causing hyperkalemia and things like that. But early on, try and get that person horizontal because that gives you some, relief of that pressure, and it also, hopefully is going to prevent some of these downstream effects. Lastly, let's talk real quickly about trench rescues. Trench rescues, to me, are one of the scariest things that's out there. I'm fairly comfortable handling a lot of things, but trench rescues just scare the bejesus out of me. And whenever I see workers digging in a trench, etc., my heart always skips a beat, especially when I recognize that they don't have the necessary safety equipment or shoring that they probably should. So be very, very careful when handling these. Stay well back from the trench lest you continue to cause, collapse of those walls. It's again important to treat this similar to a confined space where the environment down in this trench may be, less than adequate, and so the ventilation may need to be provided, et cetera. So make sure that the scene is safe. Try and, assess the patient as best you can. It may be that they are entrapped, so that you can only, assess a small portion of them. But very important that we do whatever assessment we can, even if it is, kind of from afar. Trying to keep them talking and things like that can tell us a lot. If we are in a position where it is safe for someone trained to get down into that trench with them to begin doing medical stabilization, that is very beneficial. These patients, even if they're enclosed in just dirt, can become hypothermic fairly quickly. And so hypothermia prevention is a real concern. Getting IV access to help with their fluids is also very important. Really, it's going to be the trench team or the farm rescue team that is going to be working on getting this person out. So there's going to be some protective, shoring that is going to need to be erected around this person so that we can prevent any further collapse of the material. But we need to pay special attention to the chest. It could be that, this person's head is completely above. They're able to, use their mouth and their nose, but their chest and abdomen is compressed enough by the material that they simply are not able to physically breathe. They're physically not able to, get the oxygen in and the carbon dioxide out. And so they will begin to become, asphyxiated just from pressure on the chest and abdomen. Even though their mouth and nose is freely available. Again, with these, just as it is with all these other special situations, medical direction throughout this can be very helpful. It can help guide kind of what the priorities are, and help make some of these decisions, et cetera, while the plan is kind of being established. We're going to wrap up with this video real quickly on a patient that was successfully extricated. And I thought it was pertinent. So.
At about 9:17 this evening, the Nash City Fire Department dispatch received information of an individual that fell into a hole directly below us. The hole is about 6 to 10 feet deep, and evidently when we got here, Nash City arrived, there were workers in the hole attempting to dig an individual out. That individual was buried to about center line or abdomen, and they were able to move some of the dirt. Currently, right now, the fire department from National City went and evaluated that individual. He doesn't currently have any type of injury that we're aware of, so that's a good thing. But he's stuck, and so that's the best way to put it. He's stuck from about the knees down. So currently what we have now is we have National City, San Diego, and Chula Vista here. We have urban search and rescue from San Diego and Chula Vista to attempt in what we would call a confined space / trench rescue. And so the objective is we don't want the walls to converge down on them, right? So everything has to be done very methodically, and there's a step-by-step process. So what we've done at this point is we have wood, that's plywood that's laying surrounding him to prevent dirt from further kind of caving in on him as well. Secondly, you notice there's a corrugated hose that's being introduced into the hole. They're going to attempt to try to remove some of the dirt using a vacuum process. Secondly, I've also requested assistance from our Public Works Department here in National City. They're going to be sending out a more powerful vacuum truck, and the objective would be to vacuum that dirt from around his legs, and then have a firefighter down below, and simply potentially even just having him come up the ladder. So currently right now it's a step-by-step slow process with a lot of fairly capable firefighters, as well as our urban search and rescue. I think we call them USAR, that you might be familiar with, and it will continue to move in a methodic process. Now, I think some of the questions that we may have in regards to the construction company. The construction company that we have before us is working and has a contract with the City of National City. They are working on a sewer system within the hole. So this is a planned process. They have worked and have done pre-construction meetings with the city engineering department to safely do this. So where we're going to go from here is once we safely extricate the individual, he'll be evaluated for any type of emergencies, and I've requested that the site be safed off, make sure that the hole is completely safe, that we put a 24-hour watch on this, and all construction will stop so that the city and the construction company have an opportunity to discuss with one another what might have gone wrong.
So we don't know what caused the hole when this got falling. Obviously, I know there was obviously construction, but was it like water saturation and then the ground collapsed?
I think to answer your question about water saturation, it doesn't appear that the hole's wet. I've had an opportunity to migrate in and around that. It doesn't appear that that is potentially the issue. But once again, that's where we're going to safe everything off. We're going to stop everything. We're going to put somebody on this as a security guard, and then this will be evaluated before anyone will be allowed to be reintroduced to the site, so that we got an opportunity to evaluate what might have happened to prevent it from happening again.
Okay, so right now, we're seeing this ladder behind us with this cabling system. What's happening right now?
Yeah, so the ladder is hopefully, and I'm very optimistic, I'm hoping that if once we remove the dirt from around his knees, that he simply can just navigate up the ladder. The cabling system that you see is an array of ropes and pulleys, so that if we have to introduce a harness to him, either around his waist or a full point harness around his arms and belly that we can lift him out if need be. Because if you notice, there's a tractor right behind us with the array of roping attached to that. So we could potentially open that up. Yeah?
Sorry, I got here late.
No worries.
The tractor, I see the tractor was nearby.
Correct.
Was that a big factor? Because sometimes, like, the judge could say, like, this tractor's going to make so you need certain moves back.
That's a great question that I can't answer. And I think that's the objective of once we get him out, we safe it off to make sure that it's safe. We put somebody on it to secure the site, and then there's an evaluation as to what might have caused that. Because, of course, don't want that happening here or elsewhere.
I was just going to come for all that stuff. Right?
That's normally a request. That is correct.
How unique is this type of rescue? Guy falls in the pool, you know, people performance out here, you really have a system,
Yeah.
everything like that. How difficult is it to pull something like this off?
Well, I think I'm going to use your word unique, right? What's interesting about the city of Nashville City and just the county of San Diego, we have a mutual aid agreement, which means that if we need help, we're going to get it. If we need to go into San Diego, we're going to help them. So we have this fantastic array of departments that are working together, that are experts in the field, not only in the field within San Diego County, but these urban search and rescue guys have gone to 9/11, right? And some of these really huge events outside of the United States. So we have experts here to support the departments, and we do that with one another. So it's not unusual to pull in these resources. When we pull them in, it's better to have them here and not need them and release them as needed. And that's what the battalion chief tends to do. As we see that things start to migrate, go in a more positive evolution, we start to release those crews to go back into their cities. Nothing at this point. If anything comes up,
All right, success. So I thought it was a pretty decent summarization of how these trench rescues can go. So thought the few minutes to look over it was worth it. So just to kind of begin to wrap things up, it's really important that whenever we're dealing with these kinds of situations that we are coordinating things with command. The incident command team has to be able to kind of weigh the risks and benefits of all these competing priorities that we have to come up with a cohesive plan that is not only safe but effective and efficient, and oriented towards keeping the patient also safe and cared for while we're developing the plan and successfully implementing it. Again, I can't stress enough, if you don't have the certification to do these types of environments, then your job is to stay back and provide support to the people that do have the training and experience to be able to safely do this. Unfortunately, every year firefighters are injured or killed doing these types of rescues, et cetera, when they either don't have the necessary training or the necessary experience to be able to successfully and safely carry these types of things out. All right. Any questions while I get switched over to the protocol real quickly? All right. So we do have a protocol that spells this out, S506. It's in the trauma section, and it does go through a lot of these types of things with treatment, suspension trauma, crush injury, et cetera. and helps walk you through kind of the steps medically of what you're supposed to be doing. It also links you over to the calcium administration protocol. That way, when we're getting ready to extricate somebody who's a potential crush injury, we've got that calcium ready to go, etc. It also talks about rhabdo, and potentially needing to do sodium bicarb to be able to work on correcting that. So important that you kind of refamiliarize yourself with this protocol. It's one of those ones that, because this is something that we just don't do a whole heck of a lot, it's probably worth referencing it in real time, to just refresh your memory of how much fluid you're supposed to be giving, when you're supposed to add bicarb to it, what you need to be watching for, etc. And then of course, when we get to other protocols, you can click and it should take you directly to where that protocol is. Another important thing when we're talking about calcium administration specifically is it's important that as a department, what it is that you are using, because there are different forms of calcium that exist. The most common one is calcium chloride, which is typically used in cardiac arrest, but also has that risk of skin necrosis if it goes extracellularly. A lot of departments are beginning to carry calcium gluconate. Calcium gluconate requires a higher dose, but is much safer if it gets out of the vein, and can still be used in cardiac arrest as well as these other situations. But it's important you know what you are carrying. That way you can appropriately grab the amount that you're supposed to. And the biggest thing to call out is that 1 gram of calcium chloride is equal to 3 grams of calcium gluconate. So you need more calcium gluconate than calcium chloride. So, but it goes through and it tells you exactly how you're supposed to do that. And I just saw I don't have a link, so I need to fix that. So I will fix that for the 2026 version, I guess. Other questions? All right. Well, not hearing any, that wraps it up. Thank you everybody who was able to attend. Please don't forget to, use your sign-in sheet and to fill out your post-evaluation or post-training evaluation, so that way you can get credits, etc. As is typical, I'm going to have this uploaded here, in a little bit, to my website and to YouTube. I do have the YouTube channel now up, so you can even subscribe to the YouTube channel, etc. It's not monetized. Don't worry about that. I don't like and subscribe, all that stuff, but it makes it a little easier to hopefully find stuff. So any questions come up, feel free to give me a holler. Otherwise, thanks for attending.